All right, great. Well, good morning, everyone, and welcome to our May Group Insurance Commission meeting. I feel like we had just met, and yet that was the beginning of March. So it's nice to be in springtime, which was not the case back in March. So I'd like to welcome everybody today to our meeting, especially our YouTube viewers. Very excited for today's agenda. We've got a great one as always. So I'm Valerie Sullivan. I am chairman. I am joined here by Vice Chair Bobby Kaplan. We have a new designee for ANF, so welcome Anna Friedman. We have designee Rebecca Butler from DOI. We have Martin Curley. We have Tamara Davis. We have Gerzino Garad. We have Eileen McEnany. We have Melissa Murphy Rodriguez, Kristen Pepin, Dean Robinson, Jason Silva, or he's joining. And Anna Sinenko and Catherine West. So we've got a nice group here. We also have Darren Ambler and Toby Choate on, who are leaving us. So they have circled off of the commission. So hello, Toby, are you there?
I'm here.
Toby has been with us since 2017, and he has stayed on mostly my request. He has been an amazing resource to me as the chairman and to all of the commissioners and, of course, the staff. So, Toby, from the bottom of my heart, I want to thank you for everything that you've brought to the commission throughout your tenure, and I want to wish you only the best.
Thank you very much. I went out and I found last night my original papers, and I think I got appointed in 2015. I found that little paper we got, when you join something. So I'm really saying I think I've been on the GIC for 11 years, 4 executive directors, 2 different administrations, one Republican, one Democratic, many different commissioners, and obviously working with the hardworking GIC staff. Over those, kind of reflecting upon those 11 years, is kind of 2 things that kind of made me stop and think about it. One is I'm incredibly impressed working with the GIC commissioners and staff. We've been able to work together and treat each other with dignity and respect. We all don't agree, but that dignity and respect basically builds consensus. It builds the ability to work together. My only regret over the last maybe 5 or 6 years is with the adoption of remote meetings, which I don't like personally. I know a lot of people do like them. I did not get to know many of you as I did the first 4 or 5 years when we met in person. And I'm sure there's a lot of great people that I really would have benefited by getting to know a little bit better on a personal level. But that's progress. Things move on. So I'd like to thank everybody for treating me with dignity and respect. I'd like to recognize everybody's hard work, including that of the GIC staff. Good luck in these challenging times, and hopefully I'll bump into you on the street sometime.
Oh, well, thank you. Thank you so much, Toby. It's been terrific. I know you're serving on the board of Mass Bay Community
Yes.
College, so you
Yes.
continue to offer your service to the state, and I am sure the administration is grateful not only for this dual role that you've played for the state, but also for continuing on at a very important time for community colleges. So thank you.
Okay.
Wish you the best.
Thank you very much. I'm going to sign
Thank you,
off now.
Toby. Thank you.
See you later, Matt.
And
Bye
then Darren, one of our
Care,
newest commissioners who added so much value in a very short period of time, has secured a new role and is transitioning out. So Darren, I wanted to thank you for your brief time and wish you only the best.
Thank you, Madam Chair. It's been a really wonderful experience Yeah, unfortunately, my new role happens to be in conflict with some of the rules about being on the committee, on the commission here. So it's an unusual rule. And, when I was appointed, there was a chance that I might not go back into consulting for employee benefits and practicing as a broker. So that was part of it. But the industry pulled me back in. It's my passion. I love helping employers with their benefit programs. And certainly I have really enjoyed doing that here at the GIC. Yeah, I love the passion and intellect that everyone brings here. And the dialogue that we've had has been truly amazing in just a short period of time. The paper that Toby had talked about, mine's barely out of the envelope, but it has been just an enriching experience. I appreciated getting to know many of you better, and I hope to stay in touch. And Matt, you and your team, I admire what you do. You run so lean and mean, and it's incredible. You're managing one of the largest benefit programs in the country. I don't know if that everyone's aware of that, but this plan is massive, and it has so much power behind it, and they can truly make waves. And I think that should be appreciated. So thank you so much, and I wish you all the best.
All right. Well, we wish you the best too. So give it up for Darren. Don't
Hey,
forget
Darren.
about that power. When you're out in the marketplace, you can tell municipalities, you can tell health plans, you can still join the charge on the GIC because now you're an alumni and we appreciate you. All right, last announcement, Dana Sullivan has left us as designee. She's moved on to a great new role within the administration, working for housing. I think it's Mass Housing Partnership. We enjoyed having her part of our board here, and now we are thrilled to welcome Anna Friedman, who is one of the secretariats. I didn't say that right. So Anna, instead of me letting the team know about your impressive background and what you're doing for A&F, would you please say a few words? And I want to welcome you here and excited to have you part of the team here.
Thank you, Madam Chair. I appreciate the warm welcome. I am honored to be Secretary Gorkowitz's new designee to the Commission. My title at A&F is Assistant Secretary for Administration, so I am lucky in this role to work closely with GIC. I've been in this role just since earlier this fiscal year, and our other A&F agencies. Prior to this, I most recently spent 7 years in municipal finance with the City of Salem and the town of Winthrop. Prior to that, I was a fiscal policy advisor in the Senate President's office for several years, where my portfolio included healthcare finance. And before that, I had a first stint at A&F on the budget team, where I also was working on budget matters related to GIC. So I feel like it's sort of a bit of a homecoming in some ways. So I'm really excited to engage in all of the important work in front of the Commission and work with all of you.
All right, so that's super terrific. Thank you for that background. I love that you have a finance background, and we're very excited to have you. So, seasoned pro here. All right, so as we want to move on, I want to turn the agenda over to Matt, review the agenda, and let's keep this meeting moving.
Thank you. Excuse me. Thank you, Madam Chair. So today, excuse me, in response to commissioners' requests during our last meeting on March the 5th, when we approved plan design and rates, we follow up with you today with more information about the policy of hospital price caps. And we have brought to present to you today Michael Bailett, who's the president of Bailett Health, really one of the foremost experts in the country on this policy area. He does a good deal of work with other states. So we've asked him to come, and he's agreed to give some of his insights, to talk about what other states are doing, and addressing some of the common misperceptions or criticisms that sometimes come the way of this policy. So we have Michael for that. Then we will close with just one other item. We'll have Jennifer Hewitt, our CFO, provide her budget update as we are nearing the end of the fiscal year. So that is today's agenda.
All right, great. Well, I'm looking forward to hearing from you, Michael. So thanks for being on. All right, so at this point, I'll entertain a motion. We have two sets of minutes. You may recall that we had to add a meeting in March, and it was so short between the time from our February meeting at the end of that month. So we had said at that meeting that we would have minutes out to you shortly on both. So at this point, I'll entertain a motion to approve both sets of minutes from the February 26th meeting as well as the March 5th. I know this only says February 26th, but I'd like to combine them in the interest of time. So do I have a motion?
So moved.
So Bobby is a first and a second.
Second.
I think that was Eileen. So at this point, I will ask Andrew to take a roll call, but I'm an aye on approving.
Thank you, Chair Sullivan. Vice Chair Kaplan.
Aye.
Designee Friedman.
I believe, do I need to abstain since I was not present to,
You don't
No.
need to, but you may.
I would like to abstain. Thank you.
Designee Butler.
Aye.
Commissioner Curley.
Aye.
Commissioner Davis.
Aye.
Commissioner Guerin.
Aye.
Commissioner McEnany.
Aye.
Commissioner Peppin.
Aye.
I think I heard you. Can you try?
Aye.
Okay, thank you. Commissioner Robinson. I'll come back. Commissioner Rodriguez.
Yes.
Commissioner Silva.
Yes.
Commissioner Sinenko.
Aye.
Commissioner West.
Yes.
And Commissioner Robinson. I heard an aye. The motion passes with one abstention.
Okay. Well, let's keep moving to the meat of the meeting. So, Matt, it's on to you for the executive director's report. I enjoyed reading it, as always, and there's some good stuff in there to update us on. So take it away.
Thank you, Madam Chair. So we have a number of updates on the human resources front where we've been very busy. We're happy to welcome 2 new employees to the GIC. We have John Varela, who's joined as our new Director of Human Resources. John has nearly 30 years of experience in this field and also in project management, general business experience, along with many years working in municipal government and other state agencies. He most recently worked at the MBTA. So thank you, John, for coming. Welcome. Happy to have you. We also just earlier this week welcomed Caroline LeBlanc, who is joining the operations unit in the role of office support specialist, supporting our retirees specifically. Caroline brings an extensive background in health insurance and GIC specific knowledge, as she spent 30 years at Unicare, now WellPoint, in various roles in customer service. So someone who's very, very familiar with how the GIC operates and has been supporting essentially our members throughout her career. And now we're making that formal by actually bringing her on the team. So we're thrilled to have both John and Caroline join the team. I will just say too, we have 2 positions that are posted and for which we are recruiting, a budget director position and a project manager position. So those information on those are all on our website. If you know people in your networks, please feel free to share those. On the legislative front, it's been a busy month or so on the budget. So the House passed its version of the budget in April, and the budget is now before the Senate, which is actually debating it this week. I think actually continues debate today. Senator Cindy Friedman, as part of the budget, had filed an amendment on our behalf, protecting public worker access to healthcare. This relates to one of the plan design changes that we made a few months ago, where we got approval from the commission to establish a uniform methodology for paying out-of-network services. And this is a companion piece. Those of you who will recall those discussions, we passed that plan design change, and we were seeking this accompanying language to support that change. So we're continuing to work that through the legislature. I don't know, Erica, if we had any late updates about whether that amendment from Senator Friedman was adopted. I know there was a potential it would be adopted even last evening. So
yeah, I'll have to go back to our tracking spreadsheet, which I haven't
Okay.
had a chance to do this morning, but happy to do that.
All right. So that is, just one other item, just to acknowledge that in the House of Representatives during the budget, Representative John Lawn from Watertown, who's the co-chair of the Joint Committee on Healthcare Financing, also filed an identical amendment regarding our out-of-network payment in the House. It was not adopted in the House budget, but we appreciate him filing that on our behalf. So the last item in our written report, I believe, is just a brief update on Vita Health, and I'll hand it over to Erica Schiavelli to provide that update.
Great, thanks, Matt. Just in the intervening seconds, there's no update yet on that amendment. They're still in session, and so we expect more information later today. So no update yet on that Senate amendment. Great. So just wanted to come back to the commission with a little bit of information about Vita and the transition that's happening there. First, I just want to acknowledge, that there's been a lot of concerned member feedback since the vote to eliminate coverage for GLP-1s for the treatment of obesity. Seemed a little disingenuous not to acknowledge that from the outset before we start talking about the transition to Vita. Folks are upset and concerned and worried about the transition, but we are doing our best on the communications front to make sure that folks are informed with the accurate information and that they're being directed to the appropriate places to get that information now that we're unwinding a little bit with Vita. So just to review kind of where we're at with Vita and what the plan is since the vote to eliminate coverage earlier this year. So we immediately began working with the team at Vita. It took us some time to strategize the next steps to support our members and kind of winding down the contract generally. But here's what folks really need to know. Beginning on July 1st, we'll still have Vita. They'll continue to be available to GIC members through the end of the calendar year. And that's really for weight management support and assistance with finding those private pay channels. But they will no longer be prescribing medications for weight management specifically, including GLP-1s. So this means that the prescribing authority will return to the member's community doctor or, the physician they were working with before Vita came on. And then the prior authorizations will be handled by CVS, which was the case before we implemented Vita Health. So just a few more words about how we're doing our darndest to communicate the change to members. So GIC staff with Vita and CVS have been coordinating. We have a weekly meeting to make sure we're getting the right information out to members. So to date, we have done or will do the following. So once we came to the decision about how we were going to proceed with VITA, we immediately posted a news post and an alert on our website with FAQs and additional information. We sent an email out to all GIC coordinators to ask them to pass the information along to the members at their agency as well. There is an ongoing email campaign with emails from VITA to all current GIC members currently using VITA to inform them of the change and what their next steps should be. We've implemented a social media campaign on GIC social channels that will continue on through the end of the calendar year. And we're constantly working with VITA to make updates to their interface. As we hear member feedback or points of confusion, we work with them to untangle those. So we will continue to meet regularly with VITA, monitor and manage whatever member disruption and abrasion comes our way. As I mentioned, we know that folks are feeling pretty upset about this, and so we're also working with VITA to triage any kind of member issues that are escalated. So that's where we're at with VITA,
Yeah.
Questions.
Yeah, I see that Bobby has a question, but before I give you the floor, Bobby, Erica, I just want to acknowledge the transparency and let you know I do love it from a leadership perspective and appreciate it. And while our constituents are upset, I do appreciate the level of effort that you and your team have put forth to communicate. We can't always make everybody happy. I wish we could. And so really want you to know how much I appreciate the leadership you've put here. Bobby, go ahead. You've got the floor.
Thank you. Thank you, Valerie. Erica, I just want to confirm, I guess, that for people who are either, let's say recently, that their doctor believes that they should be on a GLP-1 for weight loss, who do not have diabetes, people who do not have diabetes, and people who currently are approved for GLP-1s for weight loss through VITA, that all those people, that the requirements, right, are that the person has to have a BMI of 27 or higher, plus one of the FDA approved comorbidities like severe sleep apnea, hypertension, cardiovascular disease, and I know there's a mitochondrial condition, which I can't recall the acronym for right now, but I just want to, confirm that. And also, if you could sort of explain how the prior authorization with CVS will work. Do they need that? Does the doctor need to have prior authorization before writing the prescription or after writing the prescription? If you could, sort of help me out in that, because we're receiving lots and lots of questions from people, even though GIC has done a great job on their website of explaining it, and the FAQs are really helpful. However, people have a lot of anxiety around this. So if you could just, confirm and let me know how that's going to work, I'd appreciate it.
Sure. So just with regard to the BMI of 27 plus a comorbidity, we will be updating our FAQs on the website to outline what CVS has provided us with in terms of those conditions, so that way folks can be really clear about what would currently qualify. Of course, understanding that that's subject to change by the FDA. So we will update our FAQs with that accordingly. With regard to the prior authorization process, that's something that will sit with CVS and will return to how it was functioning prior to the implementation of VITA. So I can get more details on how that prior authorization works. I do have them. I just have not delved into them such that I can speak to them off the top of my head. But happy to come back and also include in our FAQs more detail about how that works. Andrew, is there anything you wanted to add? Oh, sorry, Madam Chair, Vice Chair.
Yeah, we are. One issue we're still pushing on is to try to get CVS to allow members. So to be clear, all prior auths are going to be shut off as of 7/1. And anyone who meets the criteria to continue to get a GLP-1 because they have the comorbid conditions will need to file a new prior auth. We are trying to get CVS to allow that process to begin prior to the shutoff, but we're still exploring whether that's possible. If we can, we'll let people know as soon as the information is available. But that is an important thing that members have to realize, is that if they have a prior auth that would have extended beyond 7/1, it is going away 7/1, and they're going to have to reapply for the prior auth. We'll have a decision tree up as soon as it's finalized about how the process works so that members can have an easy reference point.
Thank you, Andrew. I appreciate that. And thank you, Erica. Yeah, any information that you have, and as soon as you have it, would be greatly appreciated. Thank you.
So Andrew, I have a question. So our contract with CVS, and maybe this is too much in the weeds, are they charging us for all these new prior auths, and what prevents them from grandfathering in prior auths that have already been approved? It seems like it's going to delay care for members. It's going to be a terrible member experience. And do we get charged? Do we have to actually pay for the prior
No,
authorization?
we're not charged by prior auth. So that's not the issue. It's a technical issue because of the change of dropping the weight management from the formulary and then reinstating it for people who have the comorbid conditions makes the prior authorization process switches at CVS difficult to work around. And that's what we're trying to work through. It's just asking them to find a way to have it work for our membership so that they can.
Yeah.
They're going to have to start the prior auth again either way, because there's no way to shut off the GLP-1 for weight management without resetting, because we don't know who's on it right now who might qualify with comorbid conditions come 7/1. So we have to clear the slate and then start it over. We're just trying to provide a mechanism for members who may be able to have a new prior auth before the shutoff.
Okay. I get it. So
Yeah.
thank you. And with all this technology and all this AI and Darren telling us all or reminding us how much power we have, I find it incredibly difficult to believe that CVS, one of the most impressive global companies in the world, can't figure this out for us. So for what it's worth, I empower you to use every tool you have, Andrew, from a contract and vendor management perspective to at least preserve some member experience. And so, Bobby, do you have your hand up again, or you just?
Yes, I do.
Okay.
Sorry. Yes.
Because we do need to move, and
No, I know.
this
I
is
just
an
have.
important topic.
Yes, I just have one more, which is a few of my members have mentioned that their doc or CVS is telling their doctors that they can't even submit a prescription before July 1. And so people are concerned that they're going to miss, a dose or two, whatever, and are basically concerned about that. So, I certainly support everything Valerie said. And if we can get CVS to at least accept prescriptions prior to, so they can maybe process them on July 1, because it's very concerning, particularly for people who are currently on the GLP-1s. So, thank you.
All right. I think the message has been received. I see Andrew nodding, and let's move on.
Thank you, Madam Chair. And now it's my pleasure to introduce Michael Baylett, President of Baylett Health, to walk through a presentation on hospital price caps. Michael founded Baylett Health in 1997 and has since worked with a wide array of government agencies and employer purchasing coalitions in over 30 states. His professional interests focus on how purchasers and regulators can influence healthcare markets to operate as efficiently and effectively as they can. He's worked on healthcare affordability strategies, payment and delivery system reform, including accountable care organizations, medical home and episode-based payment strategy designs, and a variety of other multi-stakeholder change processes. So I've known Michael for many years. Our paths have crossed a number of times, very highly respected among policymakers. He also served as Assistant Commissioner for Benefit Plans at the Massachusetts Division of Medical Assistance, which is the state Medicaid agency. So with that, I am happy to turn the mic over to Michael to present to you today and help our commission continue on this discussion about provider prices.
Thank you, Matt, and good morning, commissioners. Pleased to be with all of you today. I am going to share with you the latest on what other states are doing in the area of hospital price caps. And then I'm going to share with you some evidence that I think counters some of the misconceptions and arguments that are often presented in response to state initiatives to cap hospital prices. I want to note that any opinions that I voice are my own as I present to you today. Let's advance a couple of slides. I think Matt covered this. We're actually up to 46 states we've now worked with. And we are based in Massachusetts in Needham. Next slide. So I'm going to do a one-page introduction on this topic. I think you are familiar with a hospital price cap concept, so I will be brief. Then I'm going to give you an overview of efforts in 5 states, and then I'm going to address some common misconceptions and arguments. And then end with my own personal opinion why I think now is an appropriate time to act on this policy. Next slide, please. Okay, so hospital price caps go by many names, reference-based pricing, payment caps, payment limits, but the general concept is to limit how high a hospital payment can be. The limits are typically defined relative to an external benchmark. Medicare is the most common one, but it's not the only one, and it doesn't have to be used. Price caps are most often applied to both inpatient and outpatient services, but the scope can vary. And as I share with you some state examples, you'll see evidence of that. Next slide, please. And one more. So to date, 5 states of varying political colors have implemented or are preparing to implement caps on hospital prices to prevent payments from being unreasonably high. Oregon was the first state in 2019. Since 2021, 4 additional states have passed legislation to implement one. I'll note that during the current legislative session, 7 states have had bills introduced, and they range from blue states like Delaware and Minnesota to red states like Oklahoma and West Virginia. Next slide, please.
I'm sorry to interrupt you, Michael. Is there one state, though, that implemented them and then reversed it?
There is one state that had their plan administrator implemented, and then when they changed plan administrators, the program went away for
Okay.
reasons that I'm not clear about, and I don't think anyone is, and that state's Montana.
Okay.
Their state employee program, they realized savings, they reported on them, and then when they changed plan administrators for reasons I'm not clear on, they did away with the program.
So if you could just remind us then, what is today's current real life states that have implemented this? It's
Yeah, those
5.
are I'm going to present those beginning on the next slide.
Okay, thank you.
Okay.
I just want us to be as clear as possible with the numbers and the facts.
Sure.
Thank you.
You'll see on the following slides that the states vary in terms of how they have designed their hospital price caps, which market they apply them to, how they value them, to what extent they make exceptions. These all vary across the states. Okay, so I'm going to walk through them, beginning with Oregon, because they were the first state to do this. And because of that, there's evaluation information about them. And then I'll describe the other states. Next slide, please. Okay, so Oregon, as I noted, began in 2019. This program is still active. They implemented it using their state purchasing authority, although they had a legislative directive to do so. And they're doing it with 2 separate health plans, one for state employees and one for school-based employees. The implementation sets a cap on hospital inpatient and outpatient services at 200% of Medicare for in-network and 185% for out-of-network. They have a number of exemptions. Oregon has pretty large rural areas, so they have exempted hospitals in those areas that include critical access hospitals, but other rural hospitals. They also exempted pediatric hospitals. Oregon's program was independently evaluated, and they were reported to save $113 million in 2021. That amounted to 7% of what their forecasted spending would have been. The reduction in out-of-pocket spending for members with outpatient procedures was higher. Okay, there have been a couple of evaluations of Oregon's program, which to some degree is served as a model for a couple of other states. Next slide, please. So on the much newer end of the spectrum is New Mexico. Their program was implemented last July, also with state purchasing authority, also with state and school-based employee health plans. Their caps are a little bit different than Oregon, the same 200% of Medicare for in-network, but they're a little lower for out-of-network at 175%. Their program applies only to urban hospitals. So New Mexico is another state that's got large rural areas. Most of the state population resides in urban areas, and that's where they applied their price cap. Now, what's interesting about New Mexico, a couple things are interesting. One is the initial legislation was specific to state and local government employees, and it was recently expanded. So they are expanding the program to their public educator health plans beginning this July. Another interesting point is New Mexico pursued price caps because they wanted to increase financial support for state employee coverage. Their state employee benefits were not particularly rich, and the price caps were a way to help finance that added support. And this program it also continues to operate. Third state is here in New England, Vermont, on the next slide. Vermont is quite different. They are in pre-implementation right now. They're going to begin this October. They are not using purchasing authority. They are using provider regulation. And they're not applying this to their public employee health plans or educator health plans. They're applying it to their entire commercial market. The exact design details are not yet finalized, but it's known that they are initially going to focus on hospital inpatient and outpatient services, but may extend the caps to other hospital-owned services. They may have exemptions, but they haven't been defined. They're not defined in statute, and they haven't been defined by the state yet. So this program is going to, as I said, cover the entire commercial market, self-insured and fully insured. The state has a requirement that they have to make sure that savings are passed along to ratepayers through lower premiums.
And hi again. Again, just want to have the facts. So did Vermont put this in front of their legislature? And then if so, how long did it take to get passed?
Their legislature directed the Vermont Green Mountain Care Board to implement this policy.
And did they need, like, what regulations did they do to do it? Did they just talk about it, or was some bill put in front of them and had to pass House and
So
Senate?
it passed in one session last year.
Okay.
Vermont has an entity called the Green Mountain Care Board that has very broad policy powers. It has the ability to regulate provider prices and has had it for years, but has never applied it. So this would be the initial application of that statutory authority that they've had but not used.
Okay, thank you. Eileen, I see you have your hand up. And you're on mute.
Sorry about that. Thank you, Valerie. Michael, so I'm very interested about Vermont. How, sorry, my screen just went blank. How they were able to get around ERISA for the self-insured, or is that still an open question? Like, do you think it will be challenged?
No, it's not an open question. They got around ERISA because they're not regulating payers, they're regulating providers.
Okay.
You can keep moving. Thank you.
Sure. Okay, the next state I want to share, the next slide is Washington. Washington is beginning their program in 2027. Their legislation passed last year, but with a lot of runway to take off, so the program doesn't start until 2027. They, in many ways, mirrored what was done in Oregon, their neighbor to the south. So again, using state purchasing authority, but with the legislative directive. So this was really an initiative of the state agency that does state purchasing, and they went to the legislature and said, hey, we would love you to direct us to do this, which the legislature did. They have a in and out of network differential that's similar to the other states. Their exemptions are a little bit different. Critical access hospitals and sole community hospitals that are not owned by large health systems are exempt if they're in rural areas. But if they're owned by the systems, then they're not exempt. And pediatric hospitals are included, but they have an alternative payment limit calculation that's not linked to Medicare. Couple of other things that distinguish Washington. They implemented their hospital price caps simultaneously with price floors for primary care and behavioral health services. So they set a floor of 150% of Medicare for primary care and behavioral health services when delivered in community settings, so outpatient services. The other thing I'll note about Washington is they separately have applied a hospital price cap to a public option program that they've offered since 2021. And that cap is even lower. That's 160% more. Okay, so you can see all of these states have some common features, but they're not identical. They've all been customized. All right, and the last state I have, this model is quite different, is Indiana. So Indiana passed their legislation last year. They have a long ramp-up period. They don't become effective till 2029. Like Vermont, Indiana is using provider regulation, and they are applying this to their full commercial market. What's different about Indiana is they are not using Medicare as a benchmark. They're using the statewide average payment as their benchmark, and they're applying their price cap to only their 5 largest nonprofit health systems. Now, no surprise, those 5 largest health systems represent the majority of spending in the state, hospital spending in the state.
That's a good one. Okay.
And their enforcement mechanism is different too. So any nonprofit hospitals that fail to meet the cap will forfeit their tax-exempt status in the state until such time as they lower their prices below the state average. Okay, so states are the laboratories of democracy, and we're seeing, different forms of innovation in these examples. Any questions about the 5 slides and where they stand? Sorry, 5 states and where they stand.
I don't, Bobby, go ahead.
Yeah, I was just, thank you, Michael, very much for this presentation. I am curious about Washington's, I guess, their floor, why they what was the rationale for establishing a price floor, since they're the only ones that seem to have done it. So I'm curious what drove that.
I know for certain about Washington that they separately, the Washington Healthcare Authority has been prioritizing strengthening their primary care system. And they've had a separate initiative focused on primary care payment, primary care reform. So their interest in increasing investment in primary care is consistent with that. I'm not sure about behavioral health, but I'm sure it was linked to a concern about adequacy of payment and access. But
Okay.
I'm not aware of a parallel effort within Washington state that's been focused on behavioral health the way that they have on primary care. I'll also note that they are not the only state to introduce the concept of a floor. Maine had a bill this year that would have capped hospital prices and introduced a floor similar to Washington. It came ever so close to passing, but it did not.
Thank you.
Sure.
Michael, I am loving this. So thank you for this detail. No other questions. We can keep moving.
Okay. So I want to pivot now to talking about arguments that are often made in these other states when they introduce their hospital price cap program. And so this information is really, if the GIC were to pursue this policy, I want you to be aware of experience in other states and what their experience and what research literature shows, so that you know how to refute certain arguments that you might hear if you decide to pursue this policy. Next slide, please. So when states begin talking about hospital price caps, no surprise, hospitals aren't enamored with the concept. And there are a number of arguments that are made that just are not rooted in evidence that I want to address. And you can see the 5 of them here. On the following slides, I'm going to address each of them. And I want you to know that in the appendix to this presentation, there are slides that have lengthy lists of references that support the counter arguments I'm going to share with you. So this isn't me making it up. There's lots that's been published to support the points that are handling. So let's go through these one at a time. For some of these 5, there are actually more than one argument that are made under the umbrella. Okay, so next slide, please. So, so argument number 1, price caps don't address the right problem. Specifically, the argument might be hospital spending growth is really due to utilization. We have, way more patients coming to see us. The issue isn't prices. That's not true. GIC data show that it's been payments per unit of service. Okay, and that's really technically what we're talking about. It's not a published or advertised price. It's the actual payment that goes to the hospital. So the payment per unit of service has been the primary driver of spending growth. That's not specific to the GIC. And it's not even specific to Massachusetts. It's really a phenomenon that's played out across the country, particularly as the delivery system has become more concentrated. That driver of payment growth and payment per unit is particularly evidenced in hospital spending and in drug spending. I'm obviously focusing on hospitals today, but I want to acknowledge it's a problem with drug spending as well.
So Michael, again, hi. Are hospitals using any kind of technology excuse because we do know that it is price growth? Like there's no data that suggests it's utilization of services. What is their argument for why prices are growing at such an enormous rate? Is it, technology, but that should be offset with AI? Do you have any
So
data?
hospitals will most often say, hey, our costs are going through the roof, and point to any number of things, labor shortage during COVID, the oil crisis with the war in Iran, all sorts of things, energy prices being up. They'll typically point to their costs going up and the higher prices being necessary to cover their costs.
Okay, thank you.
Yeah. I'll also note in any given year, utilization might bump up, but if we look longitudinally at price or payment per unit and utilization, it's clearly payment per service unit or price that's been followed. Okay, the second argument that falls under price caps don't address the right problem is on the next slide. And that is Massachusetts hospital prices really aren't so high, so we don't need a price cap here. And the response to this is a little technical, so stay with me. If you compare Massachusetts hospital prices to Medicare prices, yeah, they don't appear to be that high. But that's because Massachusetts Medicare prices are sky high. Okay. If, however, you standardize Massachusetts prices and you look at them relative to commercial hospital prices elsewhere in the country, they're quite high. So, for example, Brigham and Women's, UMass Memorial, and Mass General Brigham, they're in the 89th and 90th percentile for all hospitals in the country. Okay. So by that measure, they're really high. Okay. In addition, there is dramatic variation in prices for hospital services across the state. For some outpatient services, the differential is as high as 5-to-1. So we have some hospitals that are paid much better than other hospitals. Oh, and one other note I want to make here. So this reference to RAND. RAND publishes a study every few years that assesses hospital prices. The data that RAND uses comes from the GIC. or at least that they used in their last report. Okay, third myth under price caps don't address the right problem. Next slide, please. Hospital prices are high because hospitals are limited in their ability to reduce costs because much of their spending goes to fixed expenses and salaries and facility maintenance. This is a very common argument. I had a hospital CEO in another state say to me a couple of years ago, "Why do you keep banging on hospital prices on hospital prices when there's nothing we can do about it?" Okay, this is a common argument that you have to accept hospital costs as a given because hospitals have no ability to manage those costs. There are two responses to this. One is high hospital prices are driven by market power, not by hospital costs. There is so much evidence on this. This has been studied exhaustively. Hospitals raise their prices because they have the market power that allows them to do so. And hospitals that don't have market power, they don't raise their hospital prices because they don't have the leverage to do so. And that, to a large degree, explains the variation in hospital prices in Massachusetts or in any state. But the second response to this is hospitals can manage their operating costs more efficiently. We've done a number of case studies recently with hospitals that are in the black with very low prices. And when I shared with a couple of them that quote that I just shared about why do you keep banging on hospital prices, we can't do anything about it. Executives of hospitals, these other hospitals, have said that's just not so. There are many things that you can do, but frankly, those things aren't easy to do, and it's easier to ask for and receive higher prices if you can get them. Okay, and I'm not saying I'm not criticizing hospital executives for that, but frankly, if you can get a higher price, why don't you do that than do the really hard work of taking excessive costs out of your system? Okay, which is hard to do, and I want to acknowledge that. You'll see here, by the way, in the footnote of the slide, sources 1 and 2. So this refers to slides that are in the appendix. So if you want to see support for the information on this slide and published studies, then you can look at the slide in the appendix that refers to sources 1 and 2. Next slide, please. So I'm moving on to a second argument. Price caps will force hospitals to close and will impede access to care. Yes, if you apply a hospital price cap to a hospital that is teetering on insolvency, it will be dangerous to that hospital. But it's possible to do modeling to understand hospital financial health and the impact of cap prices. And frankly, in Massachusetts, the hospitals where the highest proportion of GIC members seek care, you see them listed here, they are all financially stable according to a broad assessment that we've performed of their financial health. They all have considerable financial reserves that could help them withstand any price constraints, including a potential GIC price cap. Now, we've provided a somewhat more detailed financial summary in the appendix, but I just want to share with you what the unrestricted funds at each of these hospitals and systems look like on the next slide. So we count their unrestricted funds in the billions. Now, they also have restricted funds, which they use as well. So I don't want you to think this is all they have for reserves, but you can see they have significant funds available to them. Okay, next slide, please. Capping hospital prices will force hospitals to leave health plan networks. To date, price cap policies in other states have not resulted in network disruptions. Okay, so hospitals might threaten to leave GIC's network, but there's no evidence that this has happened in other states, and they don't have to do this. They if they're really concerned that this would impact their bottom line, there are steps that they could take to improve their management of their costs. And I'll note that if you want to protect against this, you can cap out-of-network rates, which, as you probably noted, Oregon, Washington, New Mexico, they all did that.
Yeah. Again, I'm interrupting you only because the info is great and Tamara has a question. So go ahead, Tamara. It's nice to see you. You have the floor.
There has been considerable activity, as you know, in suburban
Can't hear you.
hospitals. Can't hear me? Oh, sorry, I didn't have my microphone on. There's been considerable activity in suburban hospitals in terms of acquisitions by bigger companies, and also the fact that suburban hospitals have fulfill an incredible need for individuals in those areas, and are not as financially stable as the big hospital networks that you just described. So how does this all impact the smaller suburban hospitals that are still urban because they're suburban? How does this impact them in relationship to the big players like MJB?
So if you were to pursue this strategy, you could, as a criterion, decide to exempt hospitals that fail to meet some measure of financial stability, or at least temporarily exempt them, while their financial status seems at risk. And I'll note, when Maine was planning their bill, that was their proposed approach, that they were going to exempt certain hospitals that were in a precarious financial state.
So this will apply also to some of the for-profit kind of hospital networks that exist?
It can. I mean, these decisions are up to the state that designs the program. And you have a bunch of design decisions that you can make in terms of which hospitals you're applying it to and which you are not. Some states have been quite broad in their application, and some much narrower.
Yeah.
Okay.
Yeah, and Michael, in Massachusetts, we have a very low for-profit.
Right.
So Tamara, in Massachusetts, which is, an opportunity here for us, obviously, we don't really have for-profit hospitals. And so I think where Michael is double clicking is the top 5 systems, that make up the majority of our constituents. And you can see that, I think where your question is relevant is some of the community hospitals that MGB has bought, like, the Nantucket Cottage or the Vineyard. I wish Jane was here because she would correct me. One of the islands hospitals is owned by MGB. Nantucket. So, if we ever get to a place, we'd want to make sure that we weren't deleteriously impacting, that rural hospital for the members who live out on the island.
Yeah.
And I might be going way over my skis, Michael, so you correct me.
So I would say when you evaluate financial stability, you need to do it at the system level and not at the hospital level, because the system has the ability to move funds around the individual hospitals. So including holding reserves at the system level, not at the hospital level. So the hospital might appear to be cash poor while the system is cash rich. So for system-owned hospitals, I would evaluate the system, not the individual hospitals.
Yeah, but my concern was the standalone community hospitals that are not owned by the majors that fulfill an incredible role in Massachusetts.
Some of those are financially weaker, but in some cases, standalone community hospitals, particularly if they have a geographic monopoly can be quite robust in their finances. So you really have to evaluate them on an individual basis. Okay, the next slide and the third argument, price caps will diminish the quality of care. There's just not strong evidence on this point. In fact, there have been many studies that have shown that the relationship between prices and quality is either weak or it's non-existent. I'll say that there's mixed evidence here. So on some narrow measures, sometimes people find there to be a relationship, but overall, price and quality does not have a strong relationship. Recently, someone asked me about a comparison of Massachusetts and Rhode Island. Rhode Island has had a hospital price growth cap, not a cap, but a price growth cap in place for 15 years. And so their prices now, which used to be about the same as Massachusetts, now are much lower. And someone said to me, so how does quality compare? Well, using Medicare's quality measures, Rhode Island looks as good, maybe a little bit better. So it's an example. There's a lot of price variation that does not appear to correlate with quality. Okay, fourth argument. There are 5 total, just so you know. On the next slide, price caps will harm the local economy. Okay, it's going to force hospitals to eliminate jobs, will harm the local economy because hospitals are big employers. The truth is, economists have looked at the impact of hospital prices on an economy, and hospital price growth hurts the economy. It results in lower economic growth, job loss, because the employers who have to spend a lot of money, and local government have to spend a lot of money on health insurance coverage, are unable to increase wages and make investments and grow. So high healthcare costs hurts the economy of Massachusetts. It is not to the benefit of Massachusetts. And there you can look at source 4 here for this, because you might think, well, that's counterintuitive. Look at all the people that they hire. Well, it's true, but look at all the other people who are not being hired for the rest of the economy, because our economy is not 100% healthcare. When we get to the point that it is, then this argument will be true. But right now, the majority of our economy is not healthcare.
Eileen?
I just have to underscore that point. I've been saying it for a long time, that the growth in healthcare does come at the expense of growth in other sectors of the economy. So just that's an important point for us all to appreciate.
Yeah, and there's a study, I think, by Zach Cooper at Yale, that's on the sources page. I think it's from them. Okay, and then the last argument, price, on the next slide, please. Price caps will lead to cost shifting. So the myth here are hospitals have to have increases in our commercial prices because Medicare and Medicaid don't pay enough. This cost shift argument is as old as any argument. And there is so much research on this that shows hospitals do not raise their prices in response to low Medicare and Medicaid payment levels. They do it to maximize their revenue. And the greatest evidence of this is that the hospitals that have the highest commercial prices are not the ones that serve the most Medicare and Medicaid patients. In fact, they're often the ones that serve the fewest Medicare and Medicaid patients. And if you look at the hospitals that serve the most Medicare and Medicaid patients, Boston Medical Center, their commercial rates are nothing like their competitors that have a much higher share of commercial. So the costs that exist within well-resourced hospitals, they are higher than they are in lower-resourced hospitals because the well-resourced hospitals make a choice to use that higher revenue that they receive to expand their services, to invest in their physical plant, and to increase their labor costs because they have access to the funds. So yes, they have higher costs, than their lower reimbursed competition because they have the money and decide to put it there. And then last, on the next slide, please. The proposed price cap will result in hospitals increasing prices for services or for health plans not covered by the price cap. This is not fully tested. I want to disclose that. We don't know how this would look if it was applied across, say, the whole commercial market, but at least in Oregon, where they implemented it for their state and school-based employee health plans, an independent evaluation by a researcher at Brown found that prices for other insurance plans and services did not go up. Okay. And, as I've said before, if a price cap limits what would be otherwise higher revenue for a hospital, the hospital or hospitals can take measures to manage their operating costs more efficiently, rather than looking for someone else to pay more. Okay, and my last slide, and this is my personal opinion slide. I think now is the time to consider a price cap for the GIC. I think following the passage of HR 1, there's less federal money coming into the state, and there's not enough money to pay for excessively high hospital prices. Further, I don't think that hospitals should look to state employees and taxpayers in Massachusetts to recoup the lost revenue that they're going to have from HR 1, especially given the huge premium increases that have been experienced recently. And now I'm ready for any questions or additional questions.
Yeah. Well, that was quite a presentation. Thank you. Eileen, you have your hand up?
Sure. So I am curious. It feels like in Massachusetts, we're reluctant to change the status quo because healthcare is such a big sector in the economy. And so I wonder how you would respond to the experience of other states isn't necessarily going to be the experience in Massachusetts. I don't know, because of kind of uniqueness of our healthcare sector.
I mean, healthcare is a big part of the economy in every state. I don't think Massachusetts is so unique. I mean, yeah, we have a greater concentration of academic medical centers than many other states do. But in terms of healthcare being a large employer within the state, that's true everywhere. And it makes policy discussions about hospital prices contentious in every state. So the 5 state examples that I gave, it was not a walk in the park for those states to advance those policies. I want to be honest about that. And I think the other states that are considering policies in this area, that it's going to be rough to get them implemented too. I think, though, hospital price policies do advance when there's a sense that we are at a moment of crisis. And I didn't share any information on this point, but there's survey data from just about every state that shows that 1/3 to 1/2 of people within the state are now avoiding going for care or delaying going for care because of cost, which means healthcare costs are so high that it's a public health problem. And so I know that in some of the other states, Vermont for sure, that state government legislators, they just got to the breaking point. They said, enough's enough. We need to fix this.
Thank you. It's well said. I don't see any other questions. I just want to thank you for this very informative presentation, fact-based. I am sure that those who require these details and these facts, especially on the myths and how to refute them, and encourage those who are part of the affordability working group that the governor put forth, that there is those that are working on this are paying attention to the need to act now, and I encourage action, because it is really heartbreaking to hear, and I'm sure some of our constituents are there, that people are avoiding care because the costs are so high, and they are pretty high. So Dean, I see you have your hand up. If you would take the floor, that would be great.
This was great and timely. And I'm curious if you could just say again, where are the references? You had mentioned an appendix.
Yeah, when you I assume you will receive this old presentation, but in slides at the back, you'll find the sources. That's
Yeah.
the,
And I would just add that in terms of public sector employment, high costs of medical care are leading to job losses. This is happening, public education across the Commonwealth. So it's more than urgent.
All right. Bobby, I see you have your hand up. Go ahead.
Yes. First, I want to thank Michael for this incredibly informative presentation with all this great data and the resource materials that you provided. And I will echo what Valerie has said, what Dean has said. It's imperative that the GIC sort of, I don't know exactly what the working group of the healthcare affordability working group is, doing. I know their recommendations are supposed to be published, at the end of, or at least provided to someone. I don't know if they can be published at the end of June, but I think it's imperative that that we as a commission support the GIC in pursuing this, this initiative, and whether, legislatively that may be a problem, may take forever. As we know, the legislature, unfortunately, very slow. And if there are other ways to possibly approach this, and what could be done, and sort of how quickly could this be done, because I think it's imperative that we do something and that we support this, because I know just from hearing from our members and also retirees who are, to Dean's point, delaying care. And it's really important. So thank you very much for all this.
Thank you, Bobby. Just knowing that you and potentially the power of the unions are behind this, I think may help those working on the affordability issues. Hey, Tamara, I see you've got your hand up.
Yes, thank you. Thank you, Michael, for a very, very informative presentation. And I think I just want to remind the commissioners that Eileen proposed at our last meeting that we consider this macro issue of price caps and alternative ways of looking at pricing in a holistic manner, rather than looking at GLP-1 separately, looking at healthcare access separately. In other words, we need to look at the big picture so that we can present. And I know the Affordability Commission is working on something, but I don't have much hope for that. That's me personally. I just think that we need to look at, what we as a commission want to do, and then have put in an action plan, and then gain the support that we need in the legislature for this action plan, including the facts and the criteria that Michael presented that could be, would be very, very helpful in supporting any of the actions that we do recommend. But if you recall, Eileen suggested that we do this, and we do it within a timely manner, meaning within hopefully the next year. So I just want to remind everybody, and it's so easy to get into the weeds and look at the little pieces. I would suggest that we look at the macro, as Eileen suggested, and do something about it, rather than just talk about it, because it is going to take a long time to persuade the political world that we need this done, and especially the hospital world that has been, getting away with doing whatever they want to do. But thank you, Eileen, for suggesting that last time.
Yeah, I think Eileen has suggested that quite often, more than just this past meeting. But you're
Well,
right, Mara.
Can I just respond? So
We
thank
voted
you.
on that, though.
I appreciate the reminder, and we all took a unanimous vote that we would try to offer such a product in 2028, rather than try to make marginal changes and put more of the cost increases on to state workers and retirees. I do just want to clarify one point. I think the legislative process, as Bobby indicated, can be very lengthy and much more contentious. And I think the GIC has the ability to control what we offer our members from a regulatory standpoint. So not sure we need to pursue the legislative avenue, because I think chances are we wouldn't get everything in place for the time frame that we're talking about.
Yeah. No, thank you, Eileen. That's really helpful. And I'm going to ask Anna, as the designee for ANF, to comment, because I'm sure she's very close to opportunities within the administration to help us. So go ahead, Anna.
Thanks, Madam Chair, and thank you, Michael, for the informative presentation. I'm actually wondering, just following on some of the questions and comments that have come up during the presentation, would a helpful next step here be evaluating some more Massachusetts-specific data to understand potentially how some of those scenarios that were presented to us this morning, like how we might understand those and with some further specific context? So I'm wondering whether the team at the GIC or others could help us understand what options we might have in terms of looking into some more specific data.
We could certainly do that. That's a good suggestion. Thank you.
Yeah, good one. Thank you. And then Bobby, I see you have your hand up.
Yes, I just wanted to sort of thank Eileen for suggesting, other ways to do this. And so if we can do this through the regulatory process as opposed to legislative, it could be a lot faster, and we might be able to implement, sort of caps the way we would like to do that, without a lot of discussion going on for years and it being sent to committee for study and then dying in committee or something like that. It would seem to me that anything we can do to work around that would be great. And thank you, Eileen. I certainly support that. And I know that my other labor commissioners would be grateful for looking at another way to do this, another approach. Thank you.
All right, great, Bobby. Thank you. I think that was our last question. Michael, do you have any parting comments, any advice for us, any motivation and call to action to really get this into our way of being for the next procurement cycle?
Well, it sounds to me like you've got the motivation already. I don't think I need to give that to you. So I would encourage you to act on it. I'll say that doing some modeling to figure out exactly how you would implement it would be an appropriate step to take, and one that other states have taken to.
Terrific. Well, thank you. Thank you very much. This has been terrific. And I want to thank the staff for listening to us, even though Eileen did push us for the vote and you have to listen to us. You brought Michael forward on a very timely presentation that will help inform your thinking and ours. So thank you. Thank you very much. All right, Jennifer, I think it's you're up and you've got plenty of time.
Yeah, just before we go to Jennifer, I just want to emphasize, first of all, thank Michael for joining us. It was an extremely helpful presentation from somebody who knows this this topic and this policy area perhaps more than any expert in the country, is my sense. And we've touched on a few times the fact that there are links to resources in the appendix upon which Michael relied on this presentation. I would just encourage commissioners to sort through some of that. And so if I can be so bold as to suggest a homework assignment for commissioners to more deeply understand this issue, there are a number of resources there that we're providing you through Michael. And with that, happy to hand it over to Jennifer.
Great. Thank you. Thank you, Matt. We love homework.
Right. Thank you so much. So my presentation today is intended as a brief report to share spending trend for the current year, as well as take an initial look at FY 2027 based on the pending House and Senate budgets. So if we could go to the next slide. This table should look familiar. It's the traditional monthly spending report for the state budget accounts, representing the employer's share of spending. What's changed on this slide from the last time I shared it at the end of February is that spending for February, March, and April have been added. The section at the top reflects pharmacy and medical claims, and the monthly detail shows the variability due to seasonality, availability of rebates to offset expenses, as well as other factors. The next slide shows the same report, but for the enrollee side of the ledger. It shows the same fluctuations as on the employer side. The following slide brings it all together and shows the state share actual spending for July 2025 through April 2026, contrasted against the original budget appropriation represented by the blue line. In April, a green line appears, and that reflects the passage of the $300 million supplemental budget, which we sorely needed. That green line continues into May and June, where spending trails off slightly, mainly because of anticipated pharmacy rebates and a shortened month in June due to the June 30th statutory spending cutoff. And then on the next slide, we're looking at the same data in another way. It's showing the cumulative growth in available funding contrasted with the cumulative spending totals. In April, the blue line of the original budget appropriation transitions to the green line to reflect the $300 million supplemental budget. That budget is now tracking more in line with actual spending. So then the next two slides, These show a similar table structure, but for different years. Some of our newer commissioners may not be aware that the GIC health benefits are funded by two different accounts. The first account is for health benefits in general and primarily covers active state employees as well as all municipal and offline authority enrollees. The second is an account that is funded via a section of the budget that covers routine transfers and is often overlooked. It was created 15 plus years ago with the purpose of reflecting so-called pay-as-you-go costs of state retiree healthcare benefits. In FY 2025, $550 million was appropriated in this manner, but only $450 million was funded in FY 26, which contributed $100 million to the FY 2026 supplemental budget. As a reminder, the remaining supplemental need came from FY 25 carry forward spending and some initial underfunding, with a small portion due to higher than projected expenses. And so you see the table here reflects the final appropriated budget, which is the General Appropriations Act, or the GAA, the $300 million supplemental that then added together becomes the total available and what we've spent through April 30th, which is reflected, which is carrying forward from the prior slides. The next slide reflects FY 27 in a similar format. And for the GIC's budget, funding levels in the House and Senate are identical to House 2, meaning they will not reflect any increases in the final GAA. Commissioners know that the House 2 funding levels reflected acceptance of all of the proposed plan design changes, but also that several were not adopted by the Commission. That results in a projected $5.25 million shortfall. In addition, the pay-as-you-go retiree health benefit account is funded at $400 million, or $150 million below what was requested by the GIC. In place of that direct funding, there is a proposal to dedicate a large percentage of excess capital gains to the State Retiree Benefits Trust Fund, or the SRBTF, for use instead of the direct funding. Unfortunately, because capital gains is a notoriously volatile funding stream, the true amount available won't be known until summer 2027 at the earliest, making it unusable as a funding source for health claims during FY 27. And thus it's reflected as a projected shortfall. Taken together, the plan design changes and SRBTF underfunding reflect an initial funding shortfall of $202.5 million in FY 27, which means that some form of a supplemental budget will be needed for the GIC in FY 27. That's a bit of a sobering way to end the meeting, but we did want to make sure that we were sharing the update with the commissioners on what we were anticipating for FY 27.
Yeah, it's very sobering. And if there's any way that there can be some innovation or some discussions with vendors for support, that would be terrific. It seems like meeting the budget is not something that we can do on a regular basis. So to the degree that the team can figure out if there is a way to save some of these growths, I'm sure that's what you're thinking as well. It's got to be just as sobering to you as it is to us as commissioners. So Jennifer, thank you. It's good to have this visibility so early in the year, and we'll look forward to some of the things that can be done appropriately. Thank you, Jennifer. I'll turn it back over to you, Matt.
See Bobby has a question or has her hand up.
Yes, thank you, Matt. It's really a comment. First of all, this certainly displays the urgent need to implement price caps. Certainly, because and the Also, the idea, I just want to comment that they would even consider, that the legislature would even consider sort of taking money from the pension fund, even though it might be capital gains, but it is the pension fund for state employees and current retirees and prospective retirees. So
Well,
that,
just to be clear, Bobby, it's not
yeah.
pension. It's
I know it's the
the
capital,
liability for
right.
for
Right.
ongoing health insurance benefits. But yes,
Right. But we it just this really demonstrates the need for us to take action sort of quickly and come up with some solution. So thanks. I just wanted to comment on that. Thank you. And thanks for the correction, Matt. I appreciate it.
Okay, Matt, no more questions, so it is officially over to you.
yep. And that concludes our presentations. And I think we move to any new business, if there is any, and then adjournment.
All right. I don't know if Eileen is still on. I know she invited all of us to a forum next week. Matt, she had to drop off for an urgency. Do you want to make a comment about that forum or anything else, since you were the one who emailed it to us?
Yeah, she. I will not. I don't have the invite handy with the details, but she did want to make sure that she forwarded that just as a resource for commissioners to learn more from Michael and others who will be providing their feedback as part of a reaction panel from industry, including both health plans and the hospital voice, among others. So yeah, would encourage folks, if they're able, to attend that.
Okay, great. Yeah, it looks like a good forum. It's next week. It helps us be educated as commissioners. So if you've got the time and can attend, would appreciate any kind of update from that when we're back together in June. Anything on your end, Matt, to bring up?
Nope, we are done. Thank you, Madam Chair. And thank
right,
you, commissioners. Excellent discussion today. Appreciate the level of engagement.
And do any other commissioners have business they'd like to bring forward? All right, then I'll give you 22 minutes back in your day. I do need a, I know, Andrew, you wanted a different way to adjourn this. We'll do that on June 18th when we're back together for our remote GIC meeting. But at this point, I would like a motion to adjourn.
So moved.
Bobby is first. How about a second?
I'll second.
Catherine seconds. And so I think if we can just in group format agree, I'm aye.
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 And so this meeting is adjourned. Have a wonderful Memorial Day weekend, and I look forward to seeing you in June. Bye, everyone.
Bye,
Thank you.
everyone.
Bye.
Bye-bye. Have a good
Bye.
weekend.